Introduce Satya Gupta, a proud Hall 3 resident. Satya, like many buckheads, has dug deep into the subject assigned to him and has put a lot of effort into this talk at multiple levels so that it will be accessible to most of us and also to the people who would like to deep dive. So without much further ado, Satya Gupta.
Thanks, Rohit. And I really have to acknowledge both you and Dilip, who helped me a lot. And so,
Hey Satya, your voice is very feeble. At least it's not easy for me to hear with my full volume. Is it the case with everyone?
It's fine for
No,
me.
Okay,
it's
there
fine for me
might be
too.
something wrong
Very
with
nice.
me. So,
Fine here too.
Prem, we are fine.
okay.
Hearing it, Prem.
Or volume button, you should consider that, boss.
all right.
दिल की बातें ठीक से सुननी पड़ेंगी भाई.
बिल्कुल, बिल्कुल. All right. So
क्या line है प्रेम?
So I'm breaking this talk into three parts. The first part is about the heart. The second part is going to be about arteries and atherosclerosis. And the third part is how do I get ahead of all of this stuff? And I expect it to finish in about 45 odd minutes, leaving about 10-15 minutes for anybody who wants to do deep dives and all. So this part is about the heart as a pump. So I'm going to have you guys inflict a video of about 3-4 minutes on you. But this is all about the electrical functioning of the heart. So
the journey starts with the sinoatrial node, or SA node, the natural pacemaker of the heart. When the SA node fires, it sends an electrical impulse that spreads across the atria. This causes the atria to depolarize, meaning the heart muscle cells change their electrical state and prepare for contraction. Shortly after depolarization, the atria contract, pushing blood into the ventricles. On the ECG, this entire electrical activation of the atria appears as the P wave, a small, rounded bump at the start of each heartbeat. It's important to remember, the P wave represents atrial depolarization. The atrial contraction follows immediately after this electrical signal. Mechanical contraction lags just slightly behind the electrical depolarization. Section 2. The AV node and the PR interval. After the atria depolarize, the electrical signal reaches the atrioventricular node, or AV node. Here, there is a deliberate delay. This AV nodal delay is critical because it gives the ventricles time to fill completely with blood from the atria before they contract. On the ECG, this pause is reflected as the PR interval, the flat section from the beginning of the P wave to the start of the QRS complex. The PR interval measures the time taken for the impulse to travel from the atria to the ventricles. Key point to remember, PR interval equals AV nodal delay equals ventricular filling time. If the PR interval is too short or too long, it suggests problems with impulse conduction between the atria and ventricles. Once the impulse leaves the AV node, it travels down the bundle of His, into the right and left bundle branches, and into the Purkinje fibers. This rapid spread of electrical activation causes the ventricles to depolarize. Depolarization of the large, thick-walled ventricles results in a powerful mechanical contraction pumping blood to the lungs and the rest of the body. On the ECG, this event is seen as the QRS complex, a sharp, spiky wave. Because the ventricles have much more muscle mass than the atria, the QRS complex is larger and more dramatic compared to the P wave. Summary. QRS complex equals ventricular depolarization equals ventricular contraction. Problems in this phase, such as a widened QRS, can suggest delays or blockages in the electrical pathways of the ventricles. Section 4. Ventricular repolarization and the T wave. After the ventricles contract and blood is ejected, the heart muscle cells need to reset a process called repolarization. Repolarization restores the original electrical state of the cells, preparing them for the next heartbeat. This recovery phase appears as the T wave on the ECG. It's important to understand that repolarization is an active, energy-dependent process, not just passive relaxation. Thus, T wave equals ventricular repolarization equals recovery and readiness for next beat. Abnormalities in the T wave, such as inversion, flattening, or peaking, can indicate ischemia, electrolyte disturbances, or other pathology.
So what
The journey starts.
what we saw here was really electrical triggers for the heart pump, but now we're going to talk a little bit about the mechanical aspects of the heart. So step one, blood flows through these veins called the inferior and the superior vena cava. This is coming from the lower parts of your body. This is coming from the upper parts of the body. Flows in into the atria, which is this little chamber out here. As this chamber gets electrically depolarized, these valves open up and the blood gets pushed from there into the ventricles. This part is the ventricle, which is what happens in step 2 here. Then in step 3, as the ventricles, you saw that in those electrical signals went into something called the bundle of His and the Purkinje fibers. Those two guys were basically scientists or doctors who kind of invented or who discovered all of this electrical signaling way back. And so when these muscles get depolarized, they start pushing blood into the lungs, into this through the pulmonary vein, and the blood goes into the lungs where it gets cleaned up and oxygenated in step 4. And in step 5, the blood comes back into the pulmonary vein. And if you'll notice here, normally, arteries have blood-rich blood, but in this particular case, the pulmonary vein has the richer blood, essentially, which is kind of squeezed back into this right portion of your, this is the right atria as opposed to the left atria here. This guy also gets depolarized, and then, it pushes its blood into the left ventricle. And when this guy gets depolarized, it basically pushes the blood back into the rota. So these are the 7 steps through which blood flows through your heart, essentially. And if anybody has any questions, it's fine to ask a question, guys. As long as I know the answer, I will answer it right away. Otherwise, we'll have to go look into a deeper dive out here later on.
So pulmonary artery is the only one that carries the deoxygenated blood?
Yeah.
And arteries you think of as
correct.
Okay.
Exactly. This is the opposite. That's why I just wanted to call out that now, because it's flowing in from the left ventricle into the lungs and back into through the vein back into the heart's right side.
And the left and right refer to always from the patient's left and patient's right, I
Yes,
guess.
and actually, there is some stats to show that normally like about 60% people have their hearts in the left-hand side of their body. But sometimes you'll find that is there on the right hand too. Those people are, you have to tell your doctor ahead of time, I guess.
Really?
Yeah, it's I know at least 3-4 people who have that situation here.
Right.
All right.
First time we are hearing this.
Yeah, it is very unusual. It shocked me the very first time, but after
Looks
that,
like their heart is at the right place.
So,
You guys don't.
how can one find out whether it is in the left or right? For example, if I want to know.
Find out heartbeat.
Heartbeat कहाँ से आ रहा है जोर से?
वो तो देखता है वो तो
You can have your wife listen to it.
अरे ये सामने कौन खड़ा है उस पर डिपेंड करता है भाई.
धड़कन. But clearly you guys don't watch enough House or didn't watch enough House. House में होता है ये सब, right side, left side.
Okay, so that's a good
Anyway,
point. Noted.
Thank you, Satya.
Nice new information.
If the heart is on the right side for somebody, would it be a mirror image or would
it is?
Would be
Pretty much.
Okay.
Body is symmetric, so it doesn't really matter. Ultimately the blood flows into the lungs and then from the lungs back into the heart. So functionally, it doesn't really matter. At least that's my understanding.
So no, it's not a mirror, Jim. Left still says left, right still says right.
Yes, well, of course. It'll be, the flow.
It'll be exact same thing, just moved over.
It just
Yeah.
shifted. Okay.
Yeah.
Also, I want to point out the artery versus vein. It doesn't depend on, rich blood or oxygen depleted blood. It's a question of where the blood is going. If the blood is going from the heart to somewhere, it's artery. If the blood is coming to the heart, it's vein.
Oh,
Usually that's the case, except for in the lungs
No, the lung thing also, right?
No, it's
Well,
from or to is saying. So, since it's going from the heart, it's an artery.
Yeah.
If coming to the heart, it's a vein.
Yes.
yeah. All right. It's a minor debate. Let's move on from this.
Yeah.
Let's look at some of these fun facts out here. I'm not going to read anything of this out here, but what's really amazing out here is that for the power consumption of an LED light, it can actually pump through 60,000 miles of arteries and capillaries, and 2.5 billion times during the lifetime of a human, and not it's pretty much a relentless machine that keeps on going. It's a little engine that can. But the one big downside out there is that if the heart muscle dies, it dies. It's not coming back again, kind of thing. As opposed to regular muscles in your skeletal muscles or in your stomach. Those are the three different types of muscles: smooth muscles that are there in your stomach and in your arteries in many ways, but not in the heart. So it's an autonomous system because it works even when you are sleeping, as opposed to you can't be running in a field when you are sleeping, kind of thing, right? So the skeletal muscles and the stomach muscles are also an example of an involuntary muscle that works independently of your brain. Skeletal muscle being the only other one that is voluntary, where you exercise your brain to exercise that particular muscle. All right.
Satya, I have one question.
Yes, please.
Uh, where does the electrical signal come to the S valve? I mean, where is it coming from?
Okay, so if you don't mind, Prem, can we push that out to later into a deeper dive, because that's a
Sure.
rabbit hole that Dilip and Rohit warned me
Oh
about.
no, any time, just
Yeah,
whenever
we'll
it
talk
comes to.
about that. We'll talk about that definitely. All right. So this is, when you are thinking in terms of a heart attack, you are really thinking of a multi-stage operation. Stage one is ischemia, where you get the blood and the oxygen deprivation occurs, and the cell begins this process of dying, or something that's called necrosis later on. Or a later stage that happens 10 to 15 minutes later. In ischemia can last up to 10 to 15 minutes, depending on how much your heart is working, and we'll see in a minute why. And infarction is when we have a total loss of oxygen, when the cell starts dying pretty much, essentially, and producing lactic acid, which causes angina pain in your chest. All right, so here's some really fun fact out here. This is the cross section of a muscle. It has many components. I'm not going to read them out to you, but this filament here that you see inside this muscle here is kind of important. It has something called actin and myosin and troponin and tropomyosin. So you see these little black spots out here. They are normally covered by the troponin. So the actin and myosin are kind of sitting out there. It's like a pole. They're sort of repelled from each, or not really attracted to each other. But as soon as some calcium ions rush into your muscle, this helical thing rotates a little bit, and these black sites get exposed, and then the myosin starts pulling on the actin. And that's what causes your muscles to contract. And then later on, after some time, the electrical signal gets turned off, the calcium goes away, and the troponin rotates back and starts covering these sites. And at that point, the muscle expands back again. So you can imagine that this guy here with these little hooks out here is pulling on, and they're coming closer to each other. And then later on, as the troponin and covers the active sites, it expands. I'm not going to go more detail into this, just to know that it's sufficient to know that this is what's responsible for contraction and expansion of your heart. So now let's look inside the cells. These are called myocytes, which are heart muscle cells and all. And so it has this little button that that Ajay Pandey also talked about. It basically opens up and lets the glucose in. The oxygen is diffuses into the cell, essentially. So now, as the glucose there's a little, almost like a assembly line, where the glucose starts breaking down and goes through this little mitochondria, which basically its job is to generate ATP, which is the energy that those myosin needs to pull on the actin fiber that you saw in the filament that you saw earlier. So stage 1 is the glycosis stage where 2 ATPs are recovered from ATP. Think of ATP as like a charge for your batteries. So it's like like a rechargeable battery is getting charged with these 2 ATP charges essentially. And then it goes through this whole cycle of citric acid cycle and the electron transport. The electron transport is where the oxygen first meets the glucose. And there is a massive push, 32 ATPs are recovered out of that. So out of this whole 4-stage operation, you get a 36 ATPs being generated essentially from this mitochondria. This ATP is used to pull, that the myosin uses to pull on the actin muscle in the heart. Any questions on this one here? All right.
Sorry, one question. So when you said once the heart muscle cells die, there's no coming back. What exactly is dying in this process that is irrecoverable?
All right. Let me jump to the next slide. This is exactly what. So what happens is that when there's too much when the cell basically has very little oxygen.
Yeah.
The first thing that kind of starts feeling the pinch out there is the electron transport chain. No more 32 ATPs. And then it back pressures on this citric acid cycle. So no more of these 2 ATPs. So all you're left with is these 2 ATPs. Now the heart, basically the muscle, the myosin wants to keep pulling on the actin, but it cannot pull anymore. Right. So when it cannot pull, there is no contraction and no blood flowing out of the ventricle back into the aorta finally at that point, right? So what happens at that point when when there's not enough ATP present out here, the citric acid cycle breaks and it starts generating lactic acid in your cell. That lactic acid starts killing off everything inside the cell membrane. And that's where you get into, for the first few minutes, it can up to 10 minutes or so. This 2 ATP stores is kind of, it produces sufficient enough oxygen to prevent the cell from dying. It's pulling a little bit, but after those around 20-minute time frame, you get to a point where it's exhausted. This 2 ATPs, the myosin can't deal with it anymore and cannot pull on the actin, and it basically, this citric acid cycle start generating lactic acid, which will kill everything in here.
So, sorry, naive question though. Marathoners talk about hitting a wall, and that's basically the production of lactic acid in their leg muscles or muscles, which is the wall saying, oh, I can't run anymore. But you don't hear about leg muscle cells dying irreversibly.
Yeah,
So
that's a great question. Like I said earlier in the talk, heart muscle doesn't regenerate, but all other muscles will regenerate.
So there's something special about the heart muscle that even when lactic
Exactly.
acid is present,
Yes.
it only kills the heart muscles, not the leg muscles,
It
etc.
kills everything, but
Interesting.
unlike the other muscles, the heart muscle, there are 3 types of muscles. The we talked about earlier: skeletal, smooth muscle, and the heart cardiac muscle. Cardiac muscles don't regenerate. This is the only little downside to the cardiac muscle.
A slight downside. Yeah, thank you.
Yeah, so Sanjay, I don't know this Rohit, I don't know the details of this, but I'm not sure it's as simple as lactic acid can only kill heart muscle. There is such a thing as over-exercise where you can destroy your muscles. But understand that while the marathoner is still getting oxygen to their muscles, right? It's they may be overtaxing the muscle, and so the production of lactic acid is greater than the blood can carry away, and so on. But
Right.
it doesn't mean that there isn't blood flow, right? Here there is no oxygen
Good
coming in.
point. There's no pumping, so it's
Yeah.
good point. Thank
So
you.
it's completely anaerobic. Yeah.
Yeah.
Yeah, if you think about this particular diagram that we saw earlier, Sanjay and Rohit, this is what the myosin is kind of, it's got a hockey stick like thing. It kind of hooks into the actin. And I have a deeper dive video, but I don't want to bore you guys with I'll lose you guys and otherwise many of them. But now we can see that later in the deep dives portion, right? That when it stops pulling, this actin and myosin is present in all muscles, whether it is skeletal muscles, smooth muscles, or cardiac muscles. But the only big difference out here in this particular case is that the cardiac muscle goes into necrosis, and we'll see in a few minutes. That is an irreversible process, and it basically is called the heart gets remodeled, which means the muscle, the dead muscle will kind of not expand and contract anymore, but the rest of the muscle will move around a little bit so that the heart cardiac boundaries are maintained essentially.
So Satya, is it true that the heart muscles, they basically move on their own as
Yes,
opposed to other muscles, and that's why they are kind of different?
exactly. The heart muscle, the cardiac muscle, and the stomach muscle, they are called the smooth muscle. Those are the only involuntary muscle. They work on their own. They don't need your brain to fire some signal off into like the skeletal muscle. If you wanted to run, you have to tell your body, hey, I want to run. And then the skeletal muscle, there's something called the parasympathetic system in your brain, which sends off signals off to your skeletal muscle and say, guys, let's go.
So, just to remind, the heart muscle and the stomach muscles, these two muscles are autonomous. They don't need brain signal. Is there
Right. The
anything else
stomach
I'm
is,
missing?
I'm just giving you stomach as an example of something called the smooth muscle. Smooth muscles
Okay,
are present in your arteries also. They're basically smooth muscles are hollow muscles.
I
And
see. Okay,
the stomach is an example. So you should think of it like that, that it's just an example.
okay, good.
But the these smooth muscles regenerate pretty rapidly and all, unlike the cardiac muscles, which are the two involuntary muscles are the cardiac and the smooth muscle. But unlike the smooth muscle, the cardiac muscle doesn't regenerate. Once it's gone, it's gone. That's why we should really pay attention to heart health, essentially. You don't
But
want your...
one thing, Satya.
Yeah.
So the heart muscles also, when they do not regenerate, but they can become stronger. Correct?
They can. There's some treatment called Entresto, which we'll talk about, which basically makes them less stiff, but they are dead anyway. It just makes them,
I,
if you basically if you have something that's totally stiff, it just won't move.
yes.
So that makes it a little bit different. If it will expand and contract, the neighbors around it will also feel the pain otherwise. If it's very stiff, the neighbors around it will also not be at their most efficient best.
I think Grish means stronger in the sense of be stiff and
There
inflexible,
is,
which is a bad thing.
yeah,
No, I
you
thought
don't
he
need...
meant I thought he meant that you can if you have very healthy mitochondria, your cells are very healthy. This entire cycle depends on how well your mitochondria are functioning, right? I mean, if they break down, it's really
It's
Mm.
over.
No. Also, after a surgery, for example, so
yeah.
there is a process of recovery, right? So
Mm.
all the muscles recover to a normal state of fitness. So that's pretty much the same muscles in
That
the
is
heart.
true. That is totally true. And the what you're doing, one of the things that people, the doctor will advise you is to go immediately into a cardiac rehab facility, kind of thing, right? I've experienced that myself. So I had the 36 sessions right after the attack, and that is extremely important because the other muscle, this remodeling, is very important. If you do that exercise, the dead muscles are basically, there's some amount of flexibility that's still left in it they can become very stiff if you don't go through the cardiac rehab.
Mm.
All right. So now that we know a little bit about the electrical and the mechanical aspects, let's look at some electrical malfunctions. Remember, we talked about the SA node and the AV node out here. When the normal heart is firing, it basically sends a very strong signal back from the SA node to the AV node. But in an unhealthy heart, this is all chaotic stuff happening out here. It is, and we'll go later on. Prem, I'm going to explain the calcium diffusion and all that kind of thing. That's what causes all of this stuff. So on an ECG or an EKG, it manifests like what you're seeing out here. Essentially, these pulses are random and they're kind of maybe close to each other or farther apart and all. Typically, what happens next is you'll get a pacemaker for if you have this chronic manner, then the treatment seems to be just the pacemaker. If there's some episodic occurrence, you normally put on something called a calcium channel blocker and beta blockers. And sometimes, if there's that's the aggressive form of treatment, most doctors will potentially ignore it if it's on a Holter's test. If it happens very infrequently, they'll ignore it. Otherwise, they'll put you on this calcium channel blockers. And if it is an emergency situation, you walk into the ER and all that kind of thing, then they'll deliver an electric shock just to reset the system so that it starts. It's like, some computer system which has gone, it's like there's some memory leak or something like that, and you have to reset it essentially. So that's what is happening in an episodic occurrence. All right. The next thing that happens is that, it's bradycardia. It's called bradycardia. And as you can see from this EKG, the pulses are farther apart from each other than the normal typical heartbeat. And, it's basically it happens to people who are on some beta blocker, like metoprolol and all, whose heart is being slowed down deliberately because they've suffered a heart attack. And, the beta blocker is supposed to slow the heart down and block the adrenaline from rushing into the heart and making it beat faster. But so the doctor will reduce your dose essentially of metoprolol or any other beta blocker that you have. Or in extreme cases, they will inject you with atropine to make your heart beat, faster than, I'm sorry, to slow the thing down like on an emergency basis. But the longer term treatment for chronic conditions is again a pacemaker here. What is a pacemaker? Pacemaker is like a little lead from this little machine out here that goes and sits on the top of the AV node, and it basically creates a shock into your atrium. It's a sort of a pseudo for like a surrogate for the SA node essentially. Okay. The next thing is, ventricular fibrillation. What we saw here was the atrium fibrillation, AFib, that's why it's called AFib. But now we're talking about VFib, which is basically part of the ventricles here. So remember, the signal goes from the SA node to the AV node to the bundle of His and the Purkinje fibers that you see here, these little sticking things that are sticking out here. So the chaotic stuff is beginning to happen out here. This can result in cardiac arrest, and right away, you die without much notice essentially. And so what the doctors typically prescribe is if your ejection fraction as part of your previous heart health has dropped to below 35, then they'll plant this cardio inverter defibrillator ICD device essentially to shock the system. It basically is noticing if the signals are coming in chaotically, and then it basically fires just to make sure that your ventricles will expand and contract just to push the blood out essentially. All right. So as you can see here, the most pacemakers today have both leads that fire on the AV node and also on the Purkinje fiber here. The third situation is, or actually the fourth one is tachycardia, where as you can see from the EKG, your heart begins to beat way too quickly and all that. So the doctors typically in an episodic treatment will inject this protein, which causes your AV node to sort of reset the circuit essentially at this point here. And so they're kind of treating it at the head so that, it's basically slowing it down so that, you get out of that situation. But if it is a chronic situation, then, there are these little cells on these channels out here, this calcium channels out here, which we'll talk about later. They are killed with you go under the knife and they kind of kill off these nodes that were firing too fast essentially. And sometimes you'll get an ICD also, like we talked about in the previous bradycardia chat also, slide there. it'll shock and reset the circuit out here. So those are the treatments for tachycardia. So we've talked about the electrical
But
issues.
yeah, one quick, so, I know a couple of people who had the ablation done. So it's only done for that condition and not for AFib?
Not for AFib. It could potentially, I don't know enough about it to be very honest, but in this part, what's really happening is some of the cells here, their electrical signals are misfiring essentially, and that's what's causing that chaotic behavior. So what the surgeon is doing is they're basically pinpointing those particular cells and turning them off and all essentially. They're deliberately killing those particular cells. Could that happen in this? Theoretically, it seems possible to me, but I don't know. I'm not enough of a doctor to tell you whether AFib can also be cured out of that or not.
Thanks. That's good to know. And second, the calcium channel blockers, is that also a treatment for blood pressure? I'm trying to understand.
I'm going to deep dive, Sanjay, on the
Okay.
in later
Channel.
on. You'll
Yeah.
see how the channels work and all essentially, and how the brain, the parasympathetic, there's something called an L channel, but I don't want to dive too deep into it right this very minute.
That's perfectly fine. Thank you.
Okay, let's talk about the mechanical failures. As you will all remember from this earlier slide that the myosin is pulling on the actin. When all of this is happening, like clockwork out there, everything's all good. But when, those muscles don't move in tandem with each other, the myosin cannot pull on the actin anymore properly. It's basically, that's what results in the mechanical failures essentially. So as you can see here in a normal aortic valve, this valve will close properly, fully, and it'll open completely out here. The surface area when it's open is quite large. But something that's had stenosis has become sort of dead, or it cannot move nicely enough and all, or it's reshaped and all. We talked about the reshaping of the muscle and all, right? So this is pretty much what's happening. This cell is not, or this valve is not opening wide enough for blood to flow. And so the conventional treatment here is valve replacement. This can be done relatively easy. There's like artificial valves. You don't have to wait for a heart transplant all the way here. Then this is fatigue essentially. So when in the normal heart, the ventricle looks a little bit like this. In a dilated heart, the ventricle has swelled essentially. Or in a atrophied heart, the ventricle has sort of become too small. And the other thing here is that fat can accumulate around out here. And we'll talk about how omega-3 and omega-6 play a role, but the fat accumulates out here and pretty much makes the valve or the ventricle not dilate and expand. It kind of limits how much blood it will push out because the fat is sitting there obstructing things and all. And then you have these stiffened walls. This is the restrictive cardiomyopathy. Basically, the muscles don't move fast enough and cannot move as much, and that causes blood to not flow out into your aorta finally at this point. So the conventional treatment, medical treatment through medicines is fluid management. They want, they'll use some sort of a Lasix to push out the water and all. And then sodium glucose, these are called, these are newer medicines called like Jardians that are SGLT2 inhibitors. Basically, they work with the kidney and they make sure water, basically what's happening is that the water is not being pulled out. The kidney is not pushing out the water through into pee. And so water gets retained and you get swelled essentially. The third medicine is called the pressure reducer. This is the Entresto that I was talking about, and lisinopril, that was the older medicine. It basically reduces the pressure on the heart, the ventricles and all, and so that it can actually move. It's not as stiff as it would be otherwise. And this is recently, I wouldn't say recently, but it's called Saku. Vitris. It's a very complicated name. I forget now, but the conventional name, the drug's name is Mentresto. And then you have these beta blockers, which are basically, they will cause your heart, the L channel and the calcium channel to open slower or faster, depending on what you want to do. And then we also talked about the scar tissue being formed. Every muscle, as we all know, when it gets injured, there's a scar tissue gets formed. So if you start treating it early enough, Prem, like you were talking about, with this medicine called Inspra, then the scar doesn't form as bad. It doesn't grow to become, it doesn't sort of start impinging on its neighbors. And otherwise, if you don't go through that cardiac rehab, like we talked about, the scar tissue kind of becomes, it starts dominating its neighbors as well. And then, of course, if you got past the point where medicine will help you, the surgically, you get an ICD and something called an LVAD, or in an extreme case, you end up in a heart transplant situation.
SV, just a quick question. A lot of words, so I may have got confused on a couple. But is this something, is hypertrophy something which is related to this part, or is it part of a different thing there?
It is. This is what is hypertrophy here. Basically, your ventricle is shrunk.
Okay.
Right. In this case, your heart, your doctors call it enlarged and all, and you have an enlarged heart and all kind of thing, right? What they're really meaning is you have an enlarged ventricle here.
Okay, and when they say ventricular, and I'm reading hypertrophy, that just basically means that the valve is becoming slightly
the ventricle,
aged.
Not the valve, but the ventricle. Remember this, let's go back to this picture here. This is the ventricle. This red and the blue parts are the ventricle. This right ventricle deals with oxygen depleted blood, and the right ventricle deals with oxygen rich blood. So imagine if this is a balloon in which, or some container in which there's blood out here. Now imagine if the thing has become smaller. It's shrunk. Right. So now it won't be able to push blood out into the aorta finally at that point.
Okay. Fine. Okay. I'll talk to you offline on some of
Sure,
this.
Sure, absolutely. All right. So the last part is the congestive heart failure, CHF. A lot of people probably know about this. This is an extreme situation. So the previous slide that we saw was myopathy. Myopathy is the sort of an intermediate stage. But once you come to the point where it's kind of end stages out there, where the heart is not being able to pump enough blood out into your arteries and all, you end up in this systolic failure or diastolic failure. Systolic failure is the earlier part when the lungs are expanding, and the diastolic portion is when the lungs are contracting and resting. So the lungs have finished, pushing the blood out. Now they are trying to recover for the next heartbeat to come in and start doing the same thing, right? But we can dive deeper into this if anybody is interested in this. And so if you look at, in the earlier stages, you kind of are trying to do the same thing that you were doing with the cardiomyopathy. But, this is an extreme stage. It's probably, we getting to the point where there's very little blood being pumped out. In the previous case, there was still some reasonable amount of blood going through. So you're still in a cardiomyopathic stage. Now you got to the point where it's too late. All right. So earlier we talked about how we'll talk about the heart and then we'll talk about the arteries. So this part of the discussion is about arteries. I'm going to inflict another video on you. It's a short one.
A heart attack isn't just a sudden event. It's the climax of a cellular energy crisis. It typically starts inside a coronary artery where a fatty plaque ruptures. This tear triggers an immediate clotting response. Platelets and fibrin clump together, forming a thrombus that completely cuts off the blood supply. Downstream, the heart muscle enters a state of ischemia. Starved of oxygen, these cells stop pumping and switch to anaerobic metabolism, creating a buildup of lactic acid that causes intense chest pain. If blood flow isn't restored within minutes, the wavefront of necrosis begins. Irreversible cell death starts at the inner layer of the heart wall and moves outward like a slow-motion wave. Because adult heart muscle cannot regenerate, the body eventually replaces the dead tissue with a stiff, fibrous scar. This scar can't beat. forcing the rest of the heart to stretch and thicken to compensate, a permanent structural change called remodeling.
All
A
right.
heart.
So let's peek inside what really happened out here. So this side here, you see a perfectly normal artery which has had no damage. There's a endothelium cells out here. And then we talked about these, Prem, we talked about smooth muscles earlier, right? These are hollow muscles in which, the content is flowing inside this. And so this is an example of a smooth muscle here. But what happens over a period of time, you have all these lipids, LDL, that your liver generates to, LDL actually, unlike, most people believe, it does some amount of good and all. It makes your, it sends some energy signals and all, but don't ask me too deep out there why, but it's not like LDL is always bad for you. Some amount of LDL is good for you. And then there's the calcium that's coming from these smooth muscles that basically, when they get inflamed, they start releasing calcium and form a plaque on top of this irritation, this inflammation that happens. So that the inflammation is sort of, it's almost like a scab that gets formed on top of the plaque here. And then there's cell debris that, that dead cells and all that have those cells that have died, that kind of starts collecting in your, on the lining out here. And then, what happens is the body sees this, these dead cells and all. It basically sends something called macrophages, which are your immune system's response, which basically tells the macro, the smooth muscles to cover it in with calcium. And then once the macrophages, they're like, like gluttonous kind of cells out there. They like to eat up all the garbage out here. And then they start generating something, some protein, which basically starts eating up on the calcium layer that is formed on. So the calcium layer on top starts getting thinner and thinner because the macrophages, in their stupor, they start eating up all the stuff that's inside here. And so at some point with more inflammation, this thin layer of calcium also bursts open. And then that's what you saw in that video there. The plaque had burst open and, it had the platelets basically start clotting out here and you end up in a thrombosis situation essentially. So this is pretty much what atherosclerosis is all about. So now look, let's see what are some of those triggers that trigger or triggers that.
Satya, can we go back to so people get a calcium score, which is basically the calcified part of this process that you were talking about, right? But I didn't realize that the calcium cap itself, I thought that was a hardened piece that just stays there. And you were saying actually that calcified piece actually could go away, and then that's when the damage starts?
Yeah, the macrophages, that the T cells in your body, your lymphatic system, it's the immune system's response. It sends macrophages to try and eat up all of this stuff. But these things like to keep on gorging, and after they're finished gorging on this debris out here, they start hitting on this calcium layer. It becomes thinner and thinner inside. That's why it will rupture it essentially.
So my understanding is the calcium score that we get through that scan is basically presence of calcium in blood that is flowing through the arteries. And that doesn't necessarily, it's basically a soft plate. It doesn't necessarily mean that the arteries are hardened, but it's an indicator of that. To actually know if the arteries are hardened or blocked, you need to do a CT. And anyway, that's my understanding of calcium
that's
score.
true. That's true. The calcium, actually, there's calcium flowing in your blood also. But this calcium is basically, nucleoblast from the macrophages here. So there's two sources. This guy basically is nothing but a bunch of calcium, which basically it sends a sealing off layer essentially.
Yeah.
But that's true. The blood also contains calcium. We'll see that in a deeper dive out there for those who are interested, how the calcium behaves. But those are the two sources of calcium.
Anyway, I'm slightly confused, but go on.
Yeah,
So the
so I
amount of
think it's
calcium in the
basically
blood.
what SV is describing is the calcified or the hard plaque, and what the scan detects is the soft plaque that which is flowing through the arteries. That's my understanding.
So I think
Yeah,
the
I
amount
think
of
this is
calcium in the blood
worthy
is
of
not
some
related
homework.
to the amount of calcium in the blood is not related to calcium score, because if you do a blood test, it will tell you how much calcium there is in your blood, and there's a typical reasonable ranges from like 9 to 10.3 or something. That's totally unrelated to
No, yeah,
calcium.
no. I'm not talking about. Yeah, you are right. It's not that calcium for sure. Yeah, that's
It is,
unrelated.
Dilip, it is the calcified stuff. You know, this is a slow process. This MMR, what the macrophages release that starts eating up the calcium that we were talking
Mm,
about out here.
mm.
It's called MMP. As I'm noting out here, it's a slow process.
Yeah.
Okay.
So, gang, Dilip, I do think there's slight difference from you. The plaque doesn't flow through your arteries. It does. There is soft plaque, and that is still attached to the arteries, and then there's hardened plaque that over time,
Okay.
as
So that
saying.
was that was
So the
my
calcium
understanding.
score is
The
about
hardened part.
is how much calcium is out there. Period. That's all it's detecting, and whether it is. So there's more in soft plaque, I presume. I don't know this, but I presume there's more in soft plaque than in hard plaque, because in the hard plaque, it's getting consumed by this process that Satya is talking about.
But I think the calcium score just picks up the hard part. That was my understanding, and then really the thing, the skinny against it was, well, it's okay, the hardened part, but really the heart attacks are caused
No. The issue is
softer
that it
part.
picks up only calcium-related plaque. There can be other plaque too. So that's the biggest issue, I believe, with the calcium score, is it gives you only the calcium-related plaque. Anyway, it's clear from listening to all of us that this is deserving of some. We don't know enough about this space,
Yeah.
right? So we each have our impressions.
But we all know our calcium score. We just don't know what it means.
Yeah. It means, look. So if you have a low calcium score, it just means that you don't have calcium-related plaque. That's it. You could have other plaque,
which is a 3-part here.
What is a calcium score mean?
So you can go get a low intensity CT scan, which will, instead of not give you all of the mapping of the artery, there's no contrast agent, nothing. It just gives you a generalized one number, which tells you how much calcium is in your arteries, right? So if there is a lot of calcium, there's a lot of plaque in your arteries, then that score is higher. And if that
Is
there's low,
is that the LPA thing?
no, LPA is very different. That's
This is all the
lipoprotein.
result of, this is all, LPA and are factors that control the amount of or propensity of deposition. This is actually deposition that has taken place on your blood vessels.
Right.
And it's essentially saying, I'm going to do a scan to see how much deposition has taken place. The issue
LPA is a blood test, and
Yeah.
the calcium score is an imaging test.
All right, guys, we have 9 minutes left.
Okay, sorry.
Keep going, yeah.
We'll dive deeper for whoever wants to stick on. So, here are some dietary triggers. As you can very well suspect, there's sugars, which are basically, what sugar does is it basically, that glucose binds to, your cellular material and all, 200 times more than anything else out there. And so that's what makes your arteries and your cells stiff, essentially. Refined carbs, when you don't have any fibers, your blood sugar will spike, because the fiber will help clean up your blood supply from the glucose in your blood, basically. Ultra processed food, I don't want to read all of this stuff, you guys can gaze at it, but the most important thing is, many people think that vegetables, people, if you're on a vegetable or a vegetarian diet, you are a little safe from being affected by this plaque business and all. But there are vegetables like onions, garlics and all that have both a mixture of sugar and glucose and fiber, which are especially bad for people with IBS and celiac disease, essentially. So don't take it literally, too literally from those who advise that stick on a plant-based diet essentially. There are other triggers that are there are chronic stress. So if you have chronic stress, your cortisol is basically firing like crazy and all. Normally, cortisol is a very helpful thing. It helps to heal inflammation. But at a point when there's constant bombardment of cortisol, then it kind of goes into overdrive and your body stops recognizing, and it just simply it stiffens your arteries and all essentially. And then certain medicines like NSAIDs, like Excedrin and stuff like that will damage your stomach lining. Sleep deprivation, everybody knows about, it basically it disrupts even your biomes in your stomach, have circadian rhythms. If you don't let them rest and all, then it basically helps to increase your inflammation count, which is measured by this HSCRP. There are all these candida that happen in your SIBO and candida in your gut and all, H. pylori that basically creates ulcers. If you happen to be consuming a whole bunch of this recent talk about tea bags having microplastic in them. So try to avoid consuming these microplastics. Smoking, carbon monoxide that comes out of smoke will basically damage the ability for the mitochondria to recover oxygen. So it ends up having detrimental effects on your lungs essentially. And of course, sedentary lifestyle. We don't want to sit there and have all the poop sitting in your colon for a long time. It'll start affecting the microbiome. Some other factors are this genetic stuff. We recently talked about, LPA and all that. Basically, there are many genes in your in that muscle that can prevent or improve or decrease the formation of nitrous oxide, which is what makes your arteries flexible. High blood pressure makes, it's like, lots of very high fluid that's coursing through your veins at a very high speed and all, or with a lot of pressure, they end up damaging the arteries as well. Oxygen deprivation, when you sleep and you have a sleep apnea condition where your SpO2 drops below 88%, that's where the heart starts pumping faster, right? Exactly when your O2 concentration level is at the lowest, and it goes into a panic situation at that point. And if you don't drink enough water, your blood viscosity drops, and having for the heart to push more viscous fluid and all makes it a little bit harder. And your liver starts producing something called fibrinogen, which increases your body's desire to create scabs and inside your arteries and all essentially. And somebody a few days ago asked what happens when you have, as you age and all kind of thing, right? The arteries basically get stiff and you end up in vascular aging. And that's typically what causes your ventricles not to push out blood as much and leading to those mechanical problems that we saw earlier. There's a very big misconception here that people have about LDL-C. I just wanted to clear this up a little bit. So think of LDL, the cholesterol that's sitting in your body, this LDL-C, as these yellow things that are sitting in a vehicle. In this case, it's a big bus, and also many of these LDL-C particles could be sitting in here. And there's one driver out here, right? This is the ApoB driver, which kind of navigates the vehicle essentially. So if there are fewer of these ApoBs, that are basically, it's like a lipoprotein that carries the cholesterol. If there are fewer of them, and they're bigger, then the chances of them attaching to some micro tear in the endothelial lining of your arteries is low. But in this particular case, where there's like, think of it as being like a bunch of motorcycles that are going, hundreds and hundreds of motorcycles, depending on how much LDL-C you have. If you have more LDL-C, then there are more of these motorcycles that are present. They will crash and burn because they are smaller. They will go and attach to micro tears that you might have in your arteries, essentially. So what doctors really have started, normally when you get a lipid panel, you're looking at your LDL-C, but what you really should be looking at is the ApoB, essentially. This is there's one ApoB driver per lipoprotein that's moving around in your artery. And so this is a more accurate measurement of your propensity to deal with it. How do you deal with the bad cholesterol essentially? So that, if you look at it, these things are colliding with the artery wall. They're smaller in size, so they'll get into smaller tears, which the larger vehicles will not get into. All right. So this is, we kind of talk literally about that, but normally doctors will not include ApoB in your LDL tests and all, but you should ask them to include that in your lipid panel essentially. Getting ahead, the last 3 slides that I have out here. Part 1, what are the things that you can do on a daily basis? Take a lot of fiber, guys. This reduces the ApoB load essentially at the amount of free cholesterol that's floating around. And then eliminate liquid sugar consumption. It causes, remember we talked about how sugar caramelizes inside your cell and stiffens the arteries and all. Prioritize omega-3, which is the good fat out there, as opposed to the inflammatory fat, which is the omega-6. EPA and DHA helps in that situation as well. And so second part, exercise and habit, it ties back into what Dilip and Rohit talked about earlier. Diet, exercise, sleep, those are the 3 big pillars out there. And of course, the 4th one was the social interaction. But these are the things that you can help yourself with, with your arteries and with your heart and your blood circulation and all. I won't read all of it. There are some of these things that you can do at home or relatively easier. The ApoB, and get your doctor to add your ApoB. LPAA, this is a genetic marker. It basically tells you how much ApoB will be floating around. And ApoA, which is basically associated with similar kind of thing that is associated with the good cholesterol, the HDL, which also goes something like that. Unlike LDL, which kind of delivers material to your arteries and to your blood, HDLA is like a garbage collection truck, basically. It basically ends up, sorry about that, it ends up clearing up the bad HDL essentially in your body. And as people were talking about earlier, do your calcium and CAC score, which is that low radiation CT scan. It's like helps to figure out what is your plaque. Any number above 0 means you have some amount of atherosclerosis in your arteries and all. And of course, EKG. That's there's no reason to not have an EKG at home. It's only $75 from Cardia. It's a very good measure of seeing how good or bad your heart is beating essentially. And it'll tell you how your ventricles and your atrium are working essentially. And so these are some wearable technologies that, if you have a Aura ring like this one here, or a watch, one of those watches essentially, it'll do really good things for you. It'll tell you about your HRV, which is basically a systemic stress. Aura ring is particularly good at it. It measures the electrical impulses based on that. And then, we've talked about CGM and having measuring controlling the glucose in your body, because as we all realize that glucose causes glycation in your cells, which is basically not very good. It stiffens your arteries and all. So people worry about diabetes, but you really should, the longer term effect of diabetes is leads into heart attacks and all. And one thing I didn't mention out here, I'm actually investing in something called cortisol. It's almost like it's like blood pressure strips essentially, except you throw saliva at it. It'll tell you how much cortisol is in your body. If normally there should be a curve out there in the morning, your cortisol should be high. That's what wakes you up and all, and then it should keep on decreasing. But if your cortisol is flat, that means you have chronic stress situation going on. There is a test. This is my last slide. There's a company called Boston Heart, and I'm sure there are other companies also out there. They will do these, not only their standard blood screening tests and all, but they'll also do in addition a cholesterol balance test. It'll give you, tell you whether you are an overproducer of cholesterol, in which case you are better off using statins. But if you are an overabsorber of cholesterol, then you need statins won't help. This is the Zetia or Ezetimibe will be the other class of medicine. This is the PCKS class of medicine and all. And then advanced inflammation markers. These are genetic tests basically that will tell you how much plaque will get generated over time and how sensitive your body is towards generating plaque. HDL map will tell you how much the omega-3 versus the good fat versus the bad fat in your body is. It's just, most lipid panels will tell you how much fat you have, how much triglycerides you have, but they will give you a little bit more deeper background here of your distribution of omega-3 and omega-6. And then there are other markers. These are SNPs of DNAs that they will actually process. They'll tell you if you are genetically disposed towards heart disease or not. And there's a full list of tests. I'll put it out here as in the group here, so you can study this. And if you can find this or other similar tests out there, I know there's a Berkeley heart diagnostic test which is more popular in California. I'm a old Bostonian, so this is where I got my tests done. And then most PCPs won't order with you without you insisting for it, and many of them don't even know about these tests and all. So you have to really be aggressive with your PCP to sort of get its orders and all. But this is worth its weight in gold. And if there are some genetic dispositions that cause your it's a tendency towards inflammation and all, it's good to repeat this test 3 to 6 months. It's only $375. It might be well worth the money that you spend on it. So that's my slide deck. I have some deeper slides for those people who are interested, but if guys, for everybody else, I'd like to thank you so much for putting up with me for this while.
Thanks. The backup
Awesome work.
material, I guess, is for people who are giving the NEET exam tomorrow.
Can we go through Q&A before going to the deeper dive?
Sure.
So I have a question, SV. Can someone have a heart attack without having any pain? Because typically they say, oh, it's a chest pain, but then I've heard. So that's question one. And question two is sometimes it's shoulder pain, sometimes chest pain. I mean, what causes pain to manifest at different places when there's a heart attack?
Okay, so Dilip, I'll be very frank. I don't know. I just have a relatively minor knowledge. But the pain that you are thinking about is when the cell basically gets, when the lactic acid, starts getting generated. That's when you start feeling the pain. Unlike people who can die without any of that stuff. Remember, we talked about VFib and all, right? It's like you just simply get into a bad electrical condition out there. It has nothing to do with the plaque and all in your body and all, right?
Right.
That results in death, instant death. You cannot escape it, basically. And then, as far as the pain is concerned, unlike, if you have leg pain and things like those, you're probably, the lactic acid is forming out there, which is what causes the pain to occur. But, unlike the cardiac cell, it will not regenerate. The skeletal muscles and all will regenerate, right? So there are these three different types of muscles that we sort of glossed over: skeletal muscle, cardiac muscle, and smooth muscles. So the cardiac muscles are the only anomaly. Once they're killed, they're killed.
Yeah, no, I think
Why
place I was going is that
the shoulder pain?
It can also be an indicator of heart attack. So that's because people typically look at only chest pain. So that's what I wanted to understand. Yeah,
So
go ahead, Rohit.
Dilip, this is Rohit. I understand that the nerves go close together, the cardiac nerve to the shoulder nerve. That's why sometimes it can manifest itself as shoulder pain. That's my understanding. I don't know that for a fact, but that's
okay.
So Dilip,
Can I speak a little?
Yeah,
Hello.
please.
Yeah, so I had an heart attack 23 years before, and I didn't have any chest pain or shoulder pain or anything except sweating. Huge amount of sweating.
Yeah.
And burping, of course.
Right.
So I didn't have any shoulder pain or burping.
Burping. I see.
Sometimes it manifests itself in indigestion. I've dealt with this with people who are undergoing a heart attack, and like whoever was speaking was saying, no pain, just upset tummy or
Yeah, I can tell you, I also suffered an heart attack about 6 years ago. I felt like I had somebody tighten a chest. I thought it was gas. I went and sat on try to purge it out and all that kind of thing. But you kind of double up on your stomach and all to purge it. But then later on, it felt like somebody had a belt across my chest, and they were tightening it like it's like 1,000 elephants sitting on my chest essentially.
Mm.
Yeah, I've heard
So
that description. The other
Yes,
part, my wife reminds me is women present themselves very differently than men. Most of these experiences that we're talking about are typical presentations in men. Women, if you're worried about your wife, etc., you may want to look into what are typical presentations for women who are suffering heart attacks.
Okay, question. Will EKG, if you're trying to figure out if it's gas versus something related to heart, will EKG, that home EKG, will that help you isolate that, or
Well,
is
we talked about this earlier that the EKG is basically, is kind of measuring something. Basically these ionic cells and all, the calcium and the potassium, and it's a very elaborate dance that you see between sodium ions and calcium ions and potassium ions and all. But if the heart is basically the signal is coming, but then it's a pretty good indicator that you're but it's not measuring the individual cells essentially, right? So if you are getting into an AFib situation, it may still look pretty good, but for a while until it actually gets to this situation, and there's no coming back from that. Like
Dilip, I think a lot of times the EKG, until it's something significant, EKG measures it at that point in time. It does not reflect if something, if a damage has taken place. Yes, it will show. But
I
if
see.
it is something which is happening, I've
At
had
that time?
cases. Yeah, like my
Right.
co-brother happened. He went to the doctor at 9 in the night, and EKG they did it because he's having all the chest pains, blah blah blah, etc. Everything else. Everything was fine. They said, Daijin Khao. And at 12 o'clock, he continued complaining, and then he was having a heart attack at 12. So it comes in sporadic things there. And I think everybody's experience is different.
I see.
The other thing I
That's
wanted
good
to,
to know.
yeah. The other thing I wanted to
But
check
one
with
more
you.
thing, Bharat,
Yeah.
one thing before you continue with that thought, having an EKG at home is actually the moment you're feeling the pain is actually
Correct.
a whole
Absolutely.
lot better. Yeah.
That's what exactly. If you're feeling something, then at that time, going to the doctor is very difficult. Doing it at home makes a huge amount of difference there. I agree with you totally. The other thing I wanted to check with you, SV, as all of us are no longer the sprightly 40s and 50s, when people have their things, a lot of us are now in the cusp of having maybe a second one there. I've heard of a lot of cases, unfortunately, and I said my co-brother was one of them. We just now heard about LMK also having Lalit Kapoor also having the same thing, that they had a second incident 10, 15 years down the line. And I think that's something which I may not be a purview of this discussion, but at least some of us who've had that experience, how do we safeguard ourselves from a second?
So, there's of course it's a very complex machine, but if you get one of these these advanced diagnostic tests done, this test here basically, what HSCRP does is basically it'll tell you about generic information, right? But these ones, this test here will tell you specifically if your arteries are inflamed or not.
Okay.
Right. So I would strongly recommend getting this done at least once.
Okay, that's a good
Just a
suggestion.
question. Just a question on this. So if your high sensitivity CRP is very low, is it still possible that your arteries are inflamed, or is the HS being the umbrella thing? It will be high if there's any inflammation going on anywhere in your body.
So if you remember from this video here, this video, all of a sudden, if the plaque ruptures and and the clot happens, it can happen instantly, pretty much. Right. So HSCRP, in my mind at least, is a slow, low grade kind of a background kind of a test. It doesn't tell you about instantaneous problem that could happen essentially.
I think having
The
a
other, so
high
this,
HSRP means you should dig deeper. Low doesn't rule out
Yes.
that you don't have plaque.
yeah, so that was my point, right? If my high sensitivity CRP is
Normal.
should
Yeah.
I get these ultra high sensitive other?
I feel so because this is, like I said, it's an instantaneous process, right? You cannot, just like with that EKG, you see a moment of time picture out there kind of thing, right? And you don't see what else is happening between those two measurements.
Can you show me the other tests? And those are not instantaneous? I mean, what are they?
I mean, this will tell you whether you're predisposed to, inflammation essentially.
I see.
Sorry, 1 second. I'm moving in the wrong direction here.
Hey, SV, I need to just jump out, but thanks a lot for this, and I will call you on offline one-on-one.
Absolutely.
Thank you.
Anytime.
Thanks, sir.
Hey, SV, I have a very simple question relatively. I keep on hearing, so I am on the cholesterol reducing medicine, and my doctor keeps on insisting. Earlier, they were saying it should be less, LDL should be less than 100, since I had a stent in my heart about 15 years back. But now they are saying that bring it down to 50 or 55 or so. So how much I should trust on these numbers, which always keeps on coming down on LDL?
So,
Any suggestion? Any idea?
yeah, so look, don't take me too literally. I'm not the doctor here.
Yes,
But
yes.
this is, to my mind, if you measure the ApoB, right, that is a better predictor of how good or bad your situation is. Some LDL is actually, believe it or not, is good for you. It delivers some, some proteins to various parts of including your brain and all. But how good or bad they are, basically think of it like a big, the more LDL that's packed inside this ApoB, think of ApoB as a bus, basically, or some vehicle in which there are many, many of these LDL, this cholesterol sitting out there, right? So as long as it's big and, and there's very few of these ApoBs, then you are okay because, it's not going to bind to these micro tears that are there in this red portion here is your artery, right? So if it's going to, the damage happens, the plaque forms when these things start hitting the endothelial lining of your artery. Okay,
Okay,
so
so
as long as
if I get this test done from that Boston lab or somewhere else, this Apple B, is there any thresholds, limits that I'm sure will come as a part of the test as to how much is good and how much is
yeah,
bad?
they give you a very detailed report, a 40-page report, and it's a really eye-opening kind of a report out there. But you don't have to go to Boston Heart for that. You can tell your PCP that you want your lipid panel to include these ApoB tests.
Oh, I see. Okay,
So
okay.
Prem, what the new guideline is that if your lipo A is normal, then there's a certain guideline. If your lipo A is high, then your guideline is much lower for LDL. So that's additional test you should do. We can talk about it when we meet
Also,
again.
also if there is cardiac history,
Yes, it's
problem
history.
history, they
Yeah,
guide towards lower numbers. So again,
correct.
Guys,
talk to Chat. He's probably up with it. But
there,
ApoB is a standard test. You could, you don't have to go to a specialized place. Just have to add it to your lipid panel. Just ask your doctor saying, "I want that," and
Okay.
and
Okay.
and HSCRP, by the way. You
SV,
should,
Yeah,
yeah.
and guys, like I may have mentioned this in another talk. I do functional health.
Yeah.
For $365, you can get 150 markers, including all the cardiac markers, all the metabolic markers, everything. Check on them once a year, once every 6 months, and you're getting a trend line of all of this, right? Because what honestly matters more is the slope sometimes than absolute levels. These absolute levels are set mean plus minus 2 sigma, right? So they're only covering 66% of the population. What matters is what's happening to you and what is the slope of what's happening to you. So, and it's specific things like people are starting to say are very dependent on you based on your risk factors, your history, and none of us are physicians. So I think specific advice for any given person is tough, man.
yeah.
Yeah, true, true. See, my worry was that, let's say 5 years back, they were talking about it should be less than 100, and doctor was very happy when it was about 80 or 90 in my case. But now suddenly they have dropped it down to 50 or 55. So I wonder sometime later they might say to bring it back to 20 or even 0. So
It could
that's
be.
where my concern
Or
is.
it could go back up to 100, man. It's just like,
Yes.
No, guys,
the sun
there is
keeps
a
around
reason
the
behind
earth.
this. There's a reason. Think of it as, there are micro tears in this endothelial lining out here, right? Your LDL, if it attaches and sticks to those tears, to those tears and all in your lining, then, that's where plaque begins essentially. So there's, the bigger the molecule out here, the smaller the chances. The bigger lipoprotein out here, less chance of it sticking to this tears. So, ApoB is actually a much better indicator, Prem, to be fair.
SV,
That's a good session. I'll get it done next time. Yes,
SV,
that's a very good session.
SV, you
Yeah.
showed some advanced testing, no? Just can you go to the slide? That advanced test you mentioned.
Right. This is what Rohit was just talking about as well.
Yeah. See, in this advanced test, I don't see anything called homocysteine.
Well, I picked out a few important ones. You can see the full list right here.
Okay. Now, what I'm saying is, I read a book by an American doctor who says homocysteine to be controlled. If homocysteine is controlled, then this forming of plaque is reduced. The propensity of forming blocks is reduced. Anything about it that you want to say?
I don't know enough about it, to be very honest.
I have not heard about homocysteine. In general, it's an important marker, right? Vitamin B, especially vegetarians.
No, but there's a full book by a doctor from America.
Yeah, but dude, that just that's n equal to 1, right? I mean, this.
Is homocysteine level part of your functional testing, Rohit?
Yes.
There you go. So it's important.
Yeah,
it's important.
It's important, especially for vegetarians. It is important, right? It's a reflection. So.
Yeah, the good news here is that these guys will give you, I'm sure, Rohit, your test.
Rohit dodged Sanjay's bullet.
Hey, Satyavrat, first of all, thanks very much for this. This was very informative and also at the same time a bit scary. Quick question for you is that if you do this advanced test, do you need a PCP to interpret it for you, or is the details enough that you can gather it from their own? Okay.
Yeah. And those people are very, very helpful. You can consult with them as well. They'll give you a diet plan and stuff like that also. It's a very nice report. And I'm sure Rohit's report is...
same, man. I mean, there is usually first of all, even though you can go pay for it, a clinician is ordering these tests, right? Some clinician they've contracted with is ordering these tests, and then they give you an interpretation by a clinician, right? They're not letting you interpret it by yourself. So there are people on the other end. It's just not your PCP. I will point out, gang, like with all of these testing, there is a decent chance of false positives, and then you'll be chasing your tail for a while. So it's a very, very personal thing. Like if you have a family history, if you have some markers that are out of sync, it's one thing. Then it's worth going deeper. And definitely, when you see a macro level issue, it's worth figuring out what is the root cause, right? And going after it. Like Satya said, the LDL could be due to 2 reasons. You could be overproducing it, you could be underabsorbing it, whatever. So you got to fix the root cause, right? As engineers, fix the root cause. Yeah. That's where the testing really helps to me, is get to root cause.
Because most people on LDL medication, either, they start with the statin, and if, they say we need to go lower, they will throw in the other kind, the Zetia.
Yeah.
Stuck on both without knowing what the real, driver should be. If the statin is, doing really effective, or is it really the Zetia that's the main path that needed to be controlled? But again, fantastic. I don't think I understood everything. Will you be sharing it?
Yeah, of course. I can put it into the chat.
Yeah, please do that.
That would be fantastic.
And there's a whole bunch of backup material and all for those who want to dive deeper and all. There's Prem, many of your questions will get answered. I know you are going for a hike and all, so I don't want to take up more time and all. But
thank you, Satya. It was very informative, and I mean many things that I hear for the first time, and since I have that issue already with me, so it's very, very important for me.
And yet you're going on a big 3,500 feet elevation will kill you.
Yeah, maybe that's, I mean,
The Three Musketeers. The Three Musketeers. Prem,
yeah.
Dilip, and Rohit are going for a 3,000 plus foot
No,
hike now.
no. It's 3 miles. 3
3
miles.
miles.
Oh, 3 miles. Okay.
Oh, okay.
500 feet. Jesus Christ. Read the description, man.
Rohit just put it in a long way.
For Patel, it's like walking to the bathroom, so.
Yeah, but in October we are planning those kinds of hikes.
Sanjay is coming for that. That's good.
Yeah.
Absolutely.
You
Absolutely.
want to say it in thousands and say 5,000 meters.
Saurabh, we can expect you to do that.
Yeah.
All right, gang. Satya, thank you so much. This was so helpful.
This was fantastic.